Good morning. Thank you for joining us this morning, everybody. I see folks trickling in. I'm Aaron Foreman. I serve as the Maryland chapter's program chair for this year. I'm just going to be kicking things off, and then I'll hand it over to our panelists. So just want to take care of a couple housekeeping items. As attendees, you are in listen-only mode and view-only mode, which means you won't be able to share your screen or speak. There will be 3 poll questions today throughout the webinar. That's to track active participation, so please respond to the poll questions. Attendees are also asked to type questions in the Q&A box, and you can type general comments in the chat box. So again, thank you for joining today. We've got a great panel today to talk about physician practice challenges and best practices. We heard from the chapter a lot of feedback that we still wanted to have some virtual offerings, and we hope that we get some feedback in our survey to follow on whether this time works for folks. We were trying to target the lunch hour to make sure folks were had the time in their day. So I want to go ahead and get started here. So as I'll introduce our moderators, and then they'll take us through the panelists on the phone today. Sarah Clark is a partner in the healthcare division at Rosen, Saperstein, and Friedlander, which is a Maryland-based business consulting, accounting, and healthcare firm. She serves as a director of healthcare services. Her clients include independent medical practices, hospital-affiliated practices, community-based clinics, FQHCs, and public health departments. Her services include reorganization, strengthening, and streamlining business infrastructure and operational practices with an eye toward improving bottom line results through strategic planning, analyzing key performance indicators, and financial statements. She's got over 20 years of healthcare administrative experience. And prior to her current role, she served as an executive director at both Doctors Community Hospital and MedStar Southern Maryland Health System. She studied undergraduate at University of Virginia and did her MBA at the College of William and Mary. So thank you to Sarah for joining us today. And Dan Murano joined Lighthouse Healthcare Advisors in 2019. He currently is in his second year as a consulting manager there. Lighthouse Healthcare Advisors assists providers in several fields, including managed care contracting, coding, compliance, and education, risk adjustment coding, healthcare management. And Dan directs projects covering service lines such as compliance, operations excellence, revenue cycle, due diligence for mergers and acquisitions, and managed care contracting. So I'm going to hand it off to Dan and Sarah, and they'll take us through the webinar today. Thank you.
Thank you, Aaron, for that introduction. So again, going to limit my time speaking here and hand it off to the panelists in a second. But really, the reason why we're here today is since the beginning of the COVID-19 pandemic, physician practices have been faced with numerous new challenges to the industry, and they cover the topics we're going to discuss today. So that includes telehealth, staffing turnover, rising costs, managed care contracts, and an increase in mergers, acquisitions, and partnerships. So before we dig into that, I'm going to pass it to each of the panelists to introduce themselves and their organization. So I'm going to start by passing it to Tim Weststein of Atlantic General Health System.
Well, good morning, everyone. It's a privilege to be a part of this today. I'm Tim Weststein. I am the Vice President of Practice Administration here at Atlantic General Hospital and Health System here on the Eastern Shore of Maryland, specifically in Berlin. Background is almost 30 years in healthcare, worked in an assortment of academic and for-profit organizations. Hopefully I can bring a couple answers to questions and contribute to share our experiences here on the Eastern Shore. I've been here for, I'll be 5 years next month. And practice operations has been something I'm very familiar with. And again, like everyone here on the call, we definitely went through the COVID pandemic. And of course, we've got several things we'd like to share today. So thank you very much, Dan and Sarah, and everyone for being a part of this.
Thank you, Tim. Next, I'm going to pass it to Barbara Taylor of Arthritis and Pain Associates of PG County.
Good morning, everyone. My name is Barbara Taylor. I'm the practice administrator for Arthritis and Pain Associates. rheumatology practice in Prince George's County, and we're opening an office in Annapolis next month. I've been here for 33 years. Practice administrator, started from one physician. We are up to 10 providers, and we've seen it all. So thank you for having me.
Thank you, Barbara. Appreciate your joining us today. Next, I'm going to give it to Dr. Jordan Stewart of Timonium Foot and Ankle.
Good morning. Good morning. Thanks for having me. My name is Jordan Stewart. I am a podiatrist in Timonium. I am.
Oh, Dr. Stewart, I think you are muted.
You hear me now?
Yes.
Sorry about that. Good morning. I'm Jordan Stewart. I'm a podiatrist in Timonium. I'm actually it keeps muting. I'm sorry. You hear me now?
Yes, we can.
Okay, sorry. I'm sorry. I don't know what's going on. I'm a solo practitioner in Timonium, Maryland. I'm a podiatrist. I've been in practice since 2006. I have a little different perspective from, I guess, the other panelists, in that I'm by myself. I'm intimately involved in the coding and billing in my practice. I'm also I've served multiple roles in the State Society in Podiatry, so I have a lot of experience with spending time in Annapolis, on Capitol Hill for legislative issues. And I also am a co-chairman of a 50 member practice management group with podiatrists throughout the state of Maryland and Virginia. So I have a lot of experience with, the different ins and outs of everyday practice management from a private practice standpoint.
Great, thank you. And then finally, I'm going to pass it to Hayden White of United Urology.
You can hear me? I don't.
Yes.
Okay, great. Okay. So yeah, I'm Hayden White. I serve as the Chief Growth Officer for United Urology Group. In terms of the Maryland, Virginia, Delaware market, the actual name that you may recognize is actually Chesapeake Urology. We, from a business perspective across the country, we go by United Urology Group, particularly in Colorado, Arizona, and Tennessee. In terms of day-to-day responsibilities, recently absorbed the payer contracting responsibility and call it Q1 of 2022, but in large part responsible for M&A partnerships, joint ventures, strategic partnerships, et cetera. So thanks for having us today, and look forward to the discussion.
Thank you, Hayden. So now that we've introduced our panel, really, I want to dive right in. And really, our first topic is one that was an immediate shock in 2020, and that was the rise of telehealth. So my initial question here for our panelists is, can you please describe your practice's experiences with telehealth? And as a follow-up, were there any challenges? And if so, what was your practice's response? So perhaps we can start with Tim, and then we could just sort of go around the horn and jump in with our other panelists.
Thank you for that question, Dan. Yeah, this was something that each one of us had a challenge with. When we started off the month of March 2020, we had already seen a lot of information about COVID being updated through media and all, and weren't sure what happened. And by mid-March, we were in the throes of it. So we quickly, as Atlantic General, we marshaled our resources with our IT team and had meetings with our physicians and advanced practitioners of how to transition from, direct patient care with our patients coming into the office and moving that to a telehealth world. The biggest thing that we used was our platform through our EMR called Follow My Health. And we had the links that we trained our staff in and our physicians in to make the connections with the patients. And very quickly, within a handful of days, it wasn't weeks, it was days, that we converted thousands of visits to the telehealth model. Unfortunately, as I'm sure a lot of people experienced, a percentage of our patients were not tech savvy. So while the physicians and all would have liked to have done what we're doing today virtually with the computer screen, a lot of that was done via telephone. So while the provider still had the ability to speak with their patient, interact and try to assess as best they could, the visual which we're experiencing today, which is what we wanted to back then, a lot of that occurred. But as I said, a portion of that did not occur. How did the community respond and all? I think they responded very well. I mean, we kept the continuity of care. We kept that connection with our patients, which I thought was critical. Can't speak to other practices, across the state as much as I can my own, but we did see a drop off that first month when COVID hit of just over 30% of previous months visit per performance, which was shocking. And then each progressive month that went by, it climbed and it got better. So it was, it's amazing how all of a sudden, schedules were full, but then it just, it dropped off there. So I think one of the things that we had a very responsive IT team. When we would run into technical difficulties, they were available to help our providers, to help that connection with the patients. It was truly a team effort. I've never experienced anything like that in healthcare, which I'm sure my colleagues will say some similar comments. But yes, it was quite a time to transition from traditional face-to-face to the virtual world. I mean, we had talked about it as initiatives here at Atlantic General in times gone by, but really could not get the traction, with the community and making the movement. And then COVID, of course, launched us into it. And of course, none of us had the option. And I can definitely compliment the providers, our IT team, our administrative support for all of that across the board. It made it very successful here. It was at times it was gut wrenching, other times it was stressful, but I can definitely say that everyone pulled together and we took care of our community here on the Eastern Shore, and continue to deliver great care. And I know there's some other things we'll get to in a moment, so I'll stop right there.
Thank you, Tim. And really, I want to open up for our panelists, so feel free to jump in when you want to talk about how your practice experienced that rise of telehealth.
I can comment if you want. I'll keep it real brief. I actually do not like telehealth at all for my practice, because unfortunately what I do as a foot and ankle specialist, I have to touch, feel, look. It's very, very challenging to manage, for primary care. Managing, medications may be a little more suitable, but I think for, foot and ankle and probably orthopedics, because I have a lot of orthopedics colleagues, it's just actually providing medical care over the computer for things that you have to look, touch, and feel. It's very hard, and quite frankly, I think there's a lot more liability from that standpoint. I mean, I know it's very limited in what you can do. It's very hard. People will call, concerned with an infection in their foot, and you look at something and maybe red. You can't differentiate between inflammation or infection just by looking at something. You really want to know if it's warm, if it's hot. So from the physical exam standpoint, I found it very hard to provide good care. The logistics that were mentioned, I agree. There were patients that it took 20 minutes to connect because they couldn't figure out how to use the app, or they couldn't figure out how to use the computer appropriately. I pretty much really only did telemedicine in my practice, and I know a lot of my colleagues only did telemedicine for absolute emergencies. From the standpoint of being able to provide care for injuries, unfortunately it's not very useful. So the in-person care coming back was really beneficial to our patients.
I can comment on Chesapeake's experience as well as our other markets. So in March of 2020, I'll take one step backwards. So in February of 2020, we did 17 telehealth visits across 150 plus providers across the country in the month. In the month of March, we ramped up to 500 in a day. And so it was an exponential level of growth in just 30 days. But that was really the only site of service that we could accommodate meaningfully, knowing that we had office shutdowns, we had, any number of protocols on how many patients we could see in the office at any given time. And frankly, the hospitals had their fair share of challenges themselves. So through the course of 2021, we averaged between 8 to 10% of all appointments were booked virtually, thinking that, in 2022, it would follow a similar pattern. Now, to Jordan's point, Dr. Stewart's point, it has tailed off. We haven't, eliminated telehealth as a site of service, as an offering. But in terms of adoption, it's probably between 3 to 5% on any given, month or week of the year. And we expect it to stay in that range. The reason we expect it to stay in that range is because it does provide clinical value for our patients. We largely cover the state of Maryland, and so reaching more remote areas is critically important for us. And so telehealth is a means to not necessarily establishing an office, but still having a presence, for specific specialties or specific, physicians that they may or may not want to see. And so that's where the business is today. I mean, we do use telehealth as a mechanism to grow, for example, virtual platforms, for example, in the recurrent UTI space. We're picking our spots where it makes sense, but to Dr. Stewart's point, a lot of physicians and APPs are starting to hesitate around usage of telehealth for more hands-on levels of care. And as urologists, like podiatry, it's similar.
I can tell you what our experience was. March 7th was a very fun weekend for us. We came in the office and rearranged all of our waiting room chairs and figured out how to do telemedicine remotely, and taught all the physicians how to do it so that Monday morning we were up and running. Switched some patients to telemedicine. We still had to bring patients in the office because of, we do joint injections. Same thing with Dr. Stewart, kind of have to have hands-on. But some of our physicians stayed home for, because they were afraid. And then some people stayed in the office, but we never shut down. We stayed open from day one. We rallied, did the homework, beforehand, and started having patients wear masks and gloves. Was probably overkill. We sanitized after every touch, and we never had an outbreak, which was wonderful.
Awesome. Well, thank you for those insights. Going on to our second topic underneath telehealth, really, I want to touch base on one thing Dr. Stewart said is a lot of patients had difficulty acclimating to the telehealth process. So perhaps starting with Dr. Stewart and then going around the horn, perhaps can each of you speak to the patient experience using telehealth and how you've had to work to maintain those patient relationships as you continue to provide care?
Well, I mean, I just in full transparency, I did not do a lot of telehealth just for the main reasons that I kind of stated. I was in a situation where my practice, I think around March 16th through about mid-May, I mean, I was only coming in for really emergencies. I think I was seeing, a handful of patients a week, and mainly they were surgical patients, or, someone that may get a gout attack or has an infection or a diabetic. But as far as the patient experience, I think the patients were very grateful and appreciative for the access to medical care. But, it was really a struggle. And, the software, although my software actually was going through a transition. So my particular situation, my old EMR actually didn't even have telehealth, which was one of the reasons that prompted me to switch EMRs. So not all of the EMRs were even up to date on telehealth. So I actually had to use an outside service for telehealth. And, there were multiple times where it was phone call back and forth. And quite frankly, there were some times where I just said, you know what, do you have FaceTime? Do you have an iPhone? And then, we just it was just becoming time prohibitive for me to spend 15 minutes to try to get them on the phone. Granted, I wasn't seeing other patients, so I had the time, but still, there were certain times I just said, you know what, let's just connect on the iPhone, and it is what it is. And you had to read a disclaimer that it was telehealth. There's a disclaimer that goes along with it that makes sure the patient knows that, there's a limited exam and limited ability to do an exam, and you're making decisions off of this. So I found it very hard. And, just again, to reiterate what I stated before, if I still get patients occasionally asking me for telehealth visits, and I just kind of tell them that I don't do it unless it's, you know, a massive emergency. So that's been my experience.
And I'll echo some of those comments, but I'll also like to add a previous comment from our first question, and that is primary care worked extremely well with telehealth, but the hands-on surgical-based specialties, that was very difficult. A urologist needs to touch a patient, a podiatrist needs to touch a patient, and surgery and orthopedic surgery and all. It's very difficult to try to really deliver acceptable care that a patient needs, you know, via the remote platform when it's surgery based, because the physician truly can't evaluate the patient accurately. I mean, and of course, with the you know, the looking at the camera, the pixel count, the integrity of the screen and the connection, yeah, there's too many variables that really put the patient at risk, but also legally put the provider at risk on that. So that was a challenge. And what I would transition now into the current question about the patient engagement, patient satisfaction. I do believe we were able to maintain that. Being here on the Eastern Shore, you know, we're, you know, a small community hospital, local health system here. You know, we're independent. You know, we take care of our local community, how everything was established about 30 years ago. So the community was already bought into supporting the hospital and everything that was taking place. So they were very pleased and enjoyed being able to have that connection. I would say that you know, it's not traditional healthcare as it was, and people were engaged. I believe they were satisfied because if everyone recalls, also at that time, depending on what source of information you got, our patients were really scared and upset because a lot of information was misinformation, disinformation, however you want to label it. So us providing the telehealth platform to have that connection for care was it was immense. And so I'm very grateful for what we were able to do today. I would echo, I think what Hayden said a few minutes ago about really curtailing the telehealth. We use it probably in our health system now in just a handful of specialties, predominantly some neurology, some psychiatry, for the service, limited and primary care now, because we chose as an organization about 2 to 3 months into COVID, we need to get the patients back in the office. We saw the benefit of telehealth, but we also started seeing the gaps and the concerns that we had. So our goal was to transition and get the patient back into the office. We still offer it as an option. Our patients are engaged and happy to have that. But to me, there's nothing that can replace the hands-on physician touch to patient that takes place during a clinical encounter.
You know, strategically, I think the organization, while it, you know, to Tim's point, we use it when we're applicable. It is certainly another extension of the practice. It gives us an additional level of flexibility for physicians that may be looking to retire and slowly phase out, maybe not spend as much time in the office. It gives, you know, again, just another site of service to reach patients that we would have otherwise not been able to see. However, I would say that there is an increasingly more and more attention that we're spending on the digitization of the business and ultimately getting to the patient as a consumer of urology services. And that is, you know, that much more accentuated coming out of COVID. Looking at other tools that we can, you know, on an asynchronous basis, discuss, you know, clinical care with patients on an ongoing basis. It's that kind of stuff that we are now much more thoughtful about thinking, you know, 1, 2, 3 years down the road, as opposed to just what's in front of us the next day. I think that has been the biggest takeaway for us in terms of COVID and making sure that we can reach patients in a number of different means.
So for us, the telehealth has been part of our practice. and it continues to, but it's a lot smaller than it used to be. We see the majority of our patients in the office, but it gives the patients that live 2 hours away more of access to the physicians. And we have patients traveling from other states, Florida, Tennessee, to get here to see their physician if they just need medication refills in a telemedicine environment. It's reduced we didn't have as many as other practices to start with, but we're definitely down to a smidgen.
Well, thank you. And going into our last question regarding telehealth, each of you touched on this, but Hayden, I know you brought up on how you plan to utilize telemedicine in the future. If each of you can just describe what percentage of your patient volume you expect to use telehealth moving into the future, and perhaps how you're preparing to shift that way. So with that, Hayden, can you start us off?
Yeah, I would say it's probably less than 5%. It's greater than 2 to 3%. It's probably going to be in the range of 3, 4, 5% of patients that we ultimately connect with telehealth. It serves a purpose. It is not going to be the lever that we use to reach all patients like it was in March of 2020. But with our younger physicians being a little bit more adept with IT and having a little bit more infrastructure than we had in place in 2019, I think it'll still be a component of the business, but I would say it's in between 3 to 5% of all patients that we'll connect with by way of virtual telehealth means.
I'll just comment that if I don't have to do it, I won't. I really don't, in my practice, I don't want to do it. And I have the infrastructure with my new AMR is great and it's easy to do, but I just don't have an interest in doing it personally. I think that, as long as we don't have another massive outbreak of COVID where people are getting deathly ill, I'm hopeful that, people will continue to come into the office and we'll be able to engage the patients. But, of course, the reality is it could always happen. There could always be something else. And we are prepared to do it. I just don't think that I can provide good care, quality care on a computer for my particular specialty. So I'm going to try to limit it. I'm not going to, I get patients asking for it all the time. And I tell my staff that they need to come in unless, I do get some patients that travel long distances. We do have some patients that will come 3-4 hours away. And in that case, I would certainly do it, particularly if it's for something non-urgent. But other than that, I really want to see the patients in my practice.
Hey, this is Tim. I would say for us, it is still part of our overall strategy and how we deliver care here at Atlantic General. But I would comment and almost repetitive of what's been said, especially by Hayden. It'll be probably more than 2%, but I would not see 4 or 5%. I mean, again, there are some specialties where it does have great benefit and flexibility for the patient and the physician. However, there's so much work that we do here in our multi-specialty group that the hands-on approach and to take care of that patient is the best medicine to deliver. So I'd say less than 5% overall for Atlantic General, but it will stay a part of our overall strategy going forward.
Our practice is probably 1%. I've got most physicians that refuse, just like Dr. Stewart, to see any telemedicine. A couple of my APPs do see a couple, here and there. And then I have one physician that dedicates 2 days to telemedicine part-time.
Awesome. Well,
I want to add that, just one thing that I think, what I noticed in my practice management group, that it is also very much age dependent. I think the older the physicians who are probably considered at higher risk for COVID, just based on age alone, or just inherently are being more protective of their health and their families, which obviously I think everybody should be, but just the reality of life and COVID, I noticed a trend that, and not just in my specialty, I'm talking just, I have a lot of friends that are physicians and family members' friends, and my father's best friend is a cardiologist, and he has some at-risk issues himself. And I would say that the physician's health kind of also, I think there's a trend that the physician's personal health and family members' health for that matter, if they have an immunocompromised family member, I think that that also dictates, their participation in telemedicine. I think that's a big factor that, we may not think about, but I think that that probably does play a big role. I assume, in the bigger groups, are you guys seeing that as well?
Agree, absolutely. Several of our senior physicians have been careful and selective on how they have done medicine and all. And yes, a lot of them had used, especially in the beginning, they're still doing it somewhat now, but when we first started, that was their main concern. Absolutely.
Okay, so I appreciate all the feedback regarding telehealth. I think that'll be very valuable to our audience today. Moving on to our next topic, I'm going to pass it to Sarah, my co-moderator, to touch on staffing and the Great Resignation.
Good afternoon, panelists. Good afternoon, participants. Thank you so much for joining us. So just in the news this week is the Minnesota Youth Association 3-day strike. And 15 nurses are participating. It's impacting 15 hospitals. So staffing shortages and provider shortages obviously leads to errors, higher morbidity, and higher mortality. So want to go around the room and see what factors are contributing to the loss of your staff and providers for your practice. We'll start with Barbara.
So in the beginning of COVID, we did a 20% reduction of staff because we had reduced how many people were in the office. I sent quite a few people home. All my billers are home. Some admin people are home. Anything that they didn't need to take up a seat, I needed space between employees. And so sometimes I laid people off and those people were, on the cusp anyway, that, weren't strong anyway. So it kind of worked itself out. I didn't replace them for quite a while. And then as time has gone by, we are busier than ever. We are seeing people are so happy to come in the office as opposed to doing telemedicine. I'm so busy, I need another physician, if not two. So I hired another APP and she is stepping up. We train them for 6 months for rheumatology. And then we have them see patients independently, always with a coach. And she's at the point now where she's starting to see patients to take on some of that load. We're at this point, we haven't lost any providers. Nobody's retired. Some people have reduced their schedules, significantly because of it and protecting their families, like has been mentioned. But otherwise, we have overhired some. It was hard to get a medical assistant that I wasn't paying $25 an hour for. So I hired non-skilled people and have trained them up myself. And I have a resource to have them tested so we can get them certified. And that has worked for me. But I've overhired the less skilled people to help us with phone calls and taking patients back, cleaning rooms. Anybody can do that.
So Barbara, just to follow up on your response, the staff that you initially laid off for the COVID crisis, did some of the same staff come back, or were these all new people that you hired and trained to replace those people?
I took a couple people back. Some people found other jobs and some people enjoyed unemployment. So, and some of them are still not working, which is, they had young children and found it was easier to stay home. And then some people were still new.
Thank you. Hayden, same question. What are the factors contributing to loss of staff and providers for your group?
Yeah, so urology is a surgical specialty. So we are, fairly competitive with, hospital systems or competitive with, other urology practices. And in post-COVID, statistically, our turnover went from, sub 10% to 16, 17, 18%. A lot of this was driven by just market forces, just increased competitiveness amongst the hospitals, amongst, participants like ourselves, looking for staff that was, had limited availability. And so, the supply demand curves became out of whack, and we were, generally on the, one of the few ways that you can combat that, although it's not the best way, is with pay. And so, as a result of the 14, 15, 16% turnover, one of the mechanisms that we used, like everyone else on this call, was pay. And I think Barbara mentioned that with respect to the medical assistance. Yet we have to run a business. We have to find ways to get more creative, which I think speaks to what Barbara just mentioned in terms of her creativity. I can't say we're as creative and hands-on as what Barbara just articulated, but our costs are up 18% from a labor perspective since COVID, which is probably not inconsistent with everyone else on this call. So as we start to see the labor markets stabilize a little bit more, and it's really only taken place in the last, call it 6 months, and things are starting to correct themselves a little bit, we're focusing that much more attention on the softer side, the non-financial levers, in terms of building our culture, building back a more family, close-knit community that we had pre-COVID. Because like Barbara, we had some involuntary turnover in which we made some changes to the headcount of the business to right-size it during COVID. And so really focusing our efforts on culture, community, and the softer side of the business to make sure we can retain staff is really what's going to carry us forward in the next couple of years.
Thank you, Hayden. Tim, what's your perspective working with a health system in terms of what have been the factors contributing to the loss of staff and providers?
Yeah, there's two things. One, I want to start with the initial, with what we did during March of 2020 through part of the summer through 2020. We furloughed about a third of our health system staff, and that was the hardest decision we ever made, because we knew that we were impacting people's lives. We knew we were impacting the organization. The drop off in health system visits, and precipitously also hospital visits and procedures and all. It unfortunately, that's what it necessitated us to do as leaders. It was very, very difficult to sit around with my colleagues in the room, it's a senior leadership, to make that decision, but it was the right decision for the organization at the time. I can say that also affected a smaller percentage of our providers, but it was both providers and staff. So it just wasn't one level there. And it was a challenge. The good news I can report today is that we were able to pull back and have our providers back into full-time status in their positions within just over 4 weeks. So that was very positive. Staff, it didn't take, I can't say the same for them, but over the course of about a 2 to 3 month period, we were able to bring everyone back, and get them back to full-time status. So that was a challenge. During that time, we didn't lose providers. We did lose a small percentage of staff who went and looked for other jobs and so on, or has been mentioned, went on unemployment. And of course, at that time, there were enhanced benefits, so that benefited them to stay in that status. One of the other challenges that we have here on the Eastern Shore, of course, where I'm actually sitting is about 5 to 6 miles from Ocean City, Maryland. And one of our biggest challenges each summer from mid-May to mid-September is the pull of local businesses providing very attractive compensation for the summer season. So our front desk people, even some of our clinical people are enticed, if you will, monetarily to go to those summer jobs. So that's a challenge for us as well. Of course, thank goodness everyone looks at their calendar, knows what the day is. We're in mid-September, so that's kind of in the rearview mirror for us for the next 9 months. But that's some of the things that happened here to us is, we went through a furlough, we're able to bring people back. And then, of course, our, biggest, tourism place, of course, in the state, Ocean City, Maryland. We have to deal with that. And it's something that, that we're aware of, that can affect, and of course, local competitors. What's a contributing thing in the area? It becomes looking for the $1, $2, whatever more per hour that we have to deal with our competitive health systems in the region, which some are 20, 25 miles away to 30 miles, and for a lot of people that is a drivable distance to get the extra compensation. And one of the other things regarding turnover and all is, yes, we have had some individuals look at where they're at in their life and where they want to be professionally. And of course, through COVID, some opted to go ahead and retire and leave the system. So.
Thank you, Tim. That's great that you actually were able to bring all your providers back and most of your staff. That's excellent. Dr. Stewart, what was your experience with loss of staff in your practice?
Yeah, so when we closed our practice in March of 2020, I laid off my staff, and I was able to retain everyone. However, when everything came back, and this was kind of a typical theme amongst my colleagues, just the morale was very poor. I think that the work ethic notably diminished. And I found that I was in a situation where I had to really flip my whole staff, which was very frustrating because they just were not motivated to book patients. I think there was some fear of the staff with COVID, even though initially the ones who were here at that time were very anti getting vaccinated. That hasn't been mentioned, but that was a big riff amongst employers and employees. I was super excited when I found out that I had access to the vaccine, and I actually made arrangements to try to get my staff the vaccine. And it never even crossed my mind, quite frankly, that they wouldn't want it. And they all looked at me like I had 10 heads, and we're like, I don't want that. This was at the time where people were dying and everybody's like fighting to get the vaccine. So, that's a big deal that we haven't talked about so far, is that, that there were employees who, despite, the issues with employment, and I think that, right now I'm in a really good spot. I have a great staff, but, we were trying the typical routes of trying to hire people through the different websites, and, the amount of people that didn't show up to interviews was insane. I would sit here and 3-4 people just wouldn't show up. Eventually we were able to recruit a new staff, which worked out well for a while, and I still wasn't satisfied. So we had some more replacements, and, we're in a much better spot now, but, we have implemented vaccination requirements in our practice. That is definitely something that I feel strongly about, just like, the flu vaccine. We've mandated, with the exception of any major medical contraindications or religious beliefs. But, the number one theme amongst all of my colleagues has been just the inability to find reliable staff, and the difficulty finding reliable staff, and the difficulty finding staff that has any good experience. I think, aside from COVID, we're in a generational gap where the work ethic is different than it was, even 10 years ago. I've been in practice this is my beginning of my 17th year, and I definitely see a difference in kind of the general, attitude of people coming in for interviews. So my experience has been that you have to be very patient to find the right employee, making sure you're not just settling, because if you settle, the odds are you're going to be interviewing someone again in 2 to 3 weeks, because that's what we've really seen happening. And really being upfront at the interviews, particularly now regarding the status of vaccinations, because I do still think that to some extent that plays a role in people's opinions of their job. And we live in such a politically contentious society that, those views, I think, have come out much more now than they were before COVID existed.
Thank you, Dr. Stewart. You do bring up a very important point about the anti-vaccination. And and the other comments you made regarding, reliable staff, staff that's engaged. I work with a behavioral health organization that was talking about the term quietly quitting and how they see that a lot now with the staffing in their organizations. So that leads to the next question: with provider and staffing burnout, what is your practice doing to maintain staffing levels? Barbara, I know you touched on having flexible schedules. Could you give us a few examples, specific examples of what you're doing to maintain providers and staff?
So I have a melting pot. Nobody has the same schedule. We used to work from 7 to 3. And then have a break, for an hour for lunch. I've got young physicians and APPs, and they want to get in and get out. So I asked them to see a certain amount of patients, and they said, well, can I see them from 7 to 1 and not have a break? Fine with me. Some people want to work all day till 3 o'clock. That's fine. And have an hour to go to the gym or whatever. That I have a variety of people that do that. But for the most part, we just try to, 7 to 3 seems to work because where we are, we're around the Beltway. So traffic is a problem. So we want to beat the traffic going in and beat the traffic going home. And I always say everybody needs to have dinner, with their family, homework, whatever you're doing in the evening. And that is our plus for, to keep people, because that suits daycare, that suits people's school activities at the end of the day, whatever their chores are at the end of the day. At least they're finished instead of leaving here at 5 or 6 and then being back at 8. That's what's worked for us.
Thank you, Barbara. And Hayden, you had talked about building culture and focusing on community. Can you give us a couple of examples of what you're doing to maintain staff and providers?
Yeah. So some of the examples that we are, really focused on, we suspended our advanced prostate cancer walk, which actually takes place this weekend. So I'll do a quick pitch if you're available and can join the Sandy Siegel prostate cancer walk / run in Towson. It's those kind of events that are really important. We haven't hosted that for 2.5 years. But that has always been an opportunity for people from the sites to interact with people from, the corporate office and bring the community together. We haven't had a Christmas party for 2.5 years. It's those kind of events and just efforts that go a long way in terms of keeping morale as high as it possibly can be, despite, frankly, there's just a lot going on in the world. But those are the type of things that we're trying to do. To refocus our energy on culture and community. And very fortunately, we have a CEO named Sandy Siegel who is really well known in the urology community, extremely focused on serving the community to the best of our business and physician abilities. And so that permeates throughout the business. And that's critically important that he serves on our board. And as our CEO, he's always, extremely focused on making sure that we, build a tight-knit culture that is ultimately best serving our communities.
Thank you, Hayden. So keeping people really connected. Tim,
Yeah.
what are you doing to maintain staffing levels? I know you say you really didn't have a huge issue with staff not coming back or providers not coming back.
Right, one of the things that's been that Hayden had just mentioned about postponing things and were canceled during COVID. We canceled our holiday events, employee appreciation events, and all those things during that first year of COVID. In the past year and a half, we brought back in the annual celebrations for our staff, our holiday Christmas parties, those things to re-engage the staff, because it's, they don't happen that often, but to just have that taken out of the, out of the mix, which, Atlantic General's been around since the early 90s. And all of a sudden for that to stop after 27, 28 years of that taking place, the staff they recognize that. So getting that normalcy back there and, celebrating people and all of that, that's very positive. And we also do an end of summer thing that we have for our staff. It's at Jolly Rogers here in Ocean City. We provide, opportunities for staff and their families to go there. So that's positive to do that. And then one of the things, money doesn't always answer the question or fix the problem. But one of the things that we did that this year, it actually started a couple of months ago now with our latest budget and putting things into place. We did do a market adjustment on looking at the staff, the clinical and the clerical support staff, to see what we could do in that realm. It was much needed. It was appropriate, and it's something that we're like, we've gone through 2+ years of COVID, and a lot of people have suffered. Couple that with the inflation that our staff, all of us are dealing with, but definitely our lower level staff, they just struggle with that. So we made a decision as our board and our senior leaders that we need to move the financial needle, and we were able to really take care of a lot of people, and really lift, as they say, a rising tide lifts all boats. We were able to lift a lot of boats, and that was very positive for the organization. Again, much needed. We operated austerely for 2+ years, and see the morale had changed, work ethic, and other things. And as I said, money doesn't fix everything, but it was something that we felt was needed at the right time to take care of our people who take care of the patients in our community. And again, not again, but separately taking care of our providers. We're really focused on that with events. Now, not only annual, but quarterly or semi-annual events to really keep people engaged, because timing and what has happened has really affected all of us. And we as an organization know if we don't take care of our staff and don't take care of our providers, bottom line, if we don't take care of them, we can't take care of the community. So that's vital to us and what we're trying to accomplish here.
Thank you, Tim.
Yeah.
And Dr. Stewart, for you, I know you said you had to get almost all together all new staff. What are you doing to maintain the staff that you have?
So, throughout the years, I've always, we do lunches every couple of weeks. We'll do holiday meals, holiday dinners. I actually find, in the past, I'd get really close to my staff, meaning, very friendly. And I continue to do that. With that being said, I think that the environment that we live in now, I think that, I maintain a friendly nature with my staff, ask them about their family, this, that, and the other, but I try not to truthfully get too deep with everything. And I just try to keep it a friendly environment. I really also, to make my staff happy, I try to encourage them to engage with the patients so that they really realize that they're an important part of the team. So, if they're engaging with the patients and they're doing active patient care, to the extent that they can provide, meaning, within their boundaries of their job description, I find that if they engage with the patients, they realize that they're a valuable member of the staff. And I really encourage that, really having them get to know the patients, understanding what the patients are coming in for, knowing why they're here. That really actually, I think, helps to build the employees' confidence, and also helps to build patient confidence in the practice. So I really try to focus on that. I think, money, I've been burned multiple times rewarding employees with a lot of money, and I reward people when it's due. But I've had a heart for people in the past where it really did not work out well for me. And I think, to Tim's point, people will walk away for $2 or $3, and you can't always win people over with money. I think really treating them like an important, valuable asset to the practice is probably the most important thing you could do to win people over. Drug companies come to us all the time, or at least they used to, with meals and stuff like that. But at the end of the day, meals only go so far. It's really just treating people, like they're part of a team and making them feel welcomed.
Thank you, panelists. I had a couple other questions, but to keep us on schedule, I'm going to pivot back to Dan. But thank you for these answers. We heard gratitude, we heard flexibility, we heard culture and connection. And so thank you for all your responses. Dan, I'll turn it back to you for the next section.
Sarah and Dan, if you don't mind, we've got a couple questions that have come in. So before we pivot topics, wanted to interject here before it gets, irrelevant. So first question from the group, and feel free to add questions to those on the line. The first question is, have the staffing pressures let up in the recent month? And have you had to increase pay to employees in order to attract and retain them? I think some of that was covered at the tail end there, but if anybody wants to weigh in on that.
Yeah, this is Tim. I'll jump in on that one. Yeah, as I said earlier, the timing of what we did a couple more months ago now regarding pay and the influence of that on the organization, we were experiencing over the past, we can always go back to March 2020, but I'll just focus on AGH. Really, within the last 12 months, it came up with more frequency from our directors that staff members were, chasing a dollar here, a dollar there. One of our biggest challenges, not so much in the health system, but the hospital, was the traveling nurse opportunities for people to take those roles. So we had lost some wonderful people who had been with us for several years. So it's been ongoing for quite some time. But I would say for us, within the last 12 months is when really we saw this becoming more of an issue. And then, of course, within the last 2 months, with what we've done as an organization, we think it's been a great benefit for us. I'm not getting the commentary anecdotally or people coming to me and say we're losing staff now because of a dollar here, $2 or whatever. So it's really been a lift. And the only other thing I'll say about money is it's not. I mean, a lot of people talk about it, but really, most people are focused on, the things that matter, and what Dr. Stewart had said a moment ago, and that is treating people right. And if people feel like they have valuable work, they contribute, and they're respected, and all of that, that goes further than a meal or even the money. The money is always short-lived, because that gives you a short, time frame, and you only get so much mileage out of that. But caring for the people, that's key.
Okay, thank you. One other question, and then Dan, you can take it over from there. How has the increase in value-based reimbursement impacted physician practices?
I can try to take both. I'm a little too slow to click unmute, but we have noticed the hospitals in particular pull back on, again, Tim, we don't really have much overlap. So we have seen the hospitals pull back in some of their aggressiveness in terms of how they pursue nursing labor, medical assistant labor. Inherently, I think Chesapeake Urology does have some advantages with respect to our schedule and, taking surgeries to an outpatient setting. And, there are some advantages just clinically for working within our organization that I think ultimately are very helpful. But pay matters. And so when the hospitals were getting just extremely aggressive across the country, it placed considerable challenges for us. And so now that we've seen the hospitals, earnings reports, and you start to see some of the commentary, they're starting to pull back on some of the aggressiveness. I think that it was unsustainable, some of the increases that they were offering to staff. And so now that has trickled down to the private practice setting where we can be more competitive. And so that's been very helpful. In terms of the value-based programs, we're actively working with generally all commercial payers on value-based programs, but in general, urology is still very much a fee-for-service specialty. We would love to see more value-based programs be put in place, but both sides need to be adequately prepared to be able to implement them. I think in the next 2 years, we'll be in a position to be able to attack or provide value-based programs in multiple subspecialties of urology, whether it's radiation oncology, robotics, or any number of different facets to urology. I think we're on the precipice. We do have some plans memorialized, but I think the effectiveness of them will only improve in the next couple of years.
And I'll just quickly add on the value-based programs as well. Atlantic General was involved with the Maryland Primary Care Program, the Delaware Primary Care First, and the Blue Cross Blue Shield patient-centered medical home programs. And, working hand in hand with these programs on the federal level with those two primary care programs and with Blue Cross as an insurance carrier, private carrier. We've moved the needle over the years as far as care and to get those dollars. But I can also echo what Hayden said. A lot of our work is still fee for service, which I don't foresee that going away anytime soon. But we all see organizationally, and we are all on board with the value of that type of reimbursement model to deliver, certain levels of care, meeting the metrics of the programs to provide for the patient's needs. One of the things we've seen specifically in primary care, preventative medicine is better than the reactive or something when someone that is not taken care of, and then occurrences or admissions to the hospital occur where it would have been more cost effective and more appropriate to have that taken care of out of the hospital, and through the preventative measures, is very valuable. It's valuable to all of us. So, and definitely to our patients and their healthcare needs. So AGH has been doing this for several years. And since I've been here, the last two programs, the primary care programs, have come under, come into existence, and we participate and we totally support them. And we look forward to the changes and how things will happen over time.
Another question came in while we were covering that, and this does relate to one of the topics that we already went over. So do any of your organizations deal with unions, and have you changed or modified how you deal with unions and the staff?
This is Tim. AGA, we don't deal with unions, so that's a quick answer for me.
We don't. So I work with Chesapeake Urology and the other practice affiliates across the country, and I can't say that we're actively working with unions today. I wish I could be more helpful. I think Tim probably does too.
Dan, I think you can take it from here.
Great. Thank you, Aaron. Our next topic is one that's been very touchy for providers all over the country, really, and that's rising costs and reimbursement strategy. So I want to open this up by just asking our panelists to expand on where else rising costs have hit your practices. And additionally, as a follow-up question there, I'll speak to how it's impacted your reimbursement strategy and your strategies for payment collection as well. And perhaps Dr. Stewart, your experience as a one doc practice, perhaps you can lead us off.
Okay. Well, it's affected everything. Just like anything in life, cost of goods go up, and obviously with COVID and, as I'm seeing the news this morning, inflation continues to rise. I think that, practicing medicine is becoming very difficult. I don't think it matters if you're an individual practitioner, a group practitioner, hospital, anyone. The cost of everything has gone up, and unfortunately, the reimbursement has not followed suit. And the downside of being an individual practitioner, although I've successfully negotiated some contracts, there are some contracts that I've unsuccessfully or haven't been able to negotiate. And every year that there's a lack of increase in reimbursement, it's actually a decrease in pay exponentially, and it just adds up over the years. I think that you have to be exceedingly savvy in the way that you run your business. You have to be very conscious of educating your staff on how not to waste things like gloves, which are, triple the cost. And, instead of putting 3 pairs of gloves on when a patient's in the room, you use, what you need to use, and you're safe about it. And, understanding that when there's bulk purchasing power, such as, being part of a big purchasing group, you utilize that. taking advantage of discounts and coupons where you can. I mean, anybody can do that, and it does make a huge difference. I think that the gouging, which we saw during COVID, has kind of simmered down. I mean, I can't even begin to tell you what I paid for KN95 masks when they first came out. We all did. We ordered them from China in our practice management group, and we paid, I think, for 100 masks, we paid like $100, or excuse me, $300 for like 100 masks, which is it was insane, but we were desperate. So, from my standpoint, I'm trying to leverage as much cash business as I can, meaning insurance, non-covered insurance services. Obviously, number one priority is do what's best for the patient, but at the same time, there are services that a patient qualifies for and they can benefit from it, and it doesn't have to deal with insurance, then that's always easier. I can talk about this topic for 3 hours, so I don't want to, I don't want to hog the screen. But the bottom line is that there's so many strategies that I think need to be implemented. I think people really need to take the time to make sure they're really pre-verifying benefits before patients come to the office and collecting deductibles, co-insurance, co-pays, collecting money. This is still a business. Medicine is a business. No one goes to work for free. It doesn't mean that you need to, jack a bill up on someone unnecessarily. With that being said, you're allowed to provide service, get paid for your services. And we need to make a concerted effort to educate our staff on collecting for the services at the time of the service. So, I can expand on that as needed, but I'll let some other people jump in.
Can you guys hear me? Sorry.
Yes.
Yeah, so I would echo what Jordan just said. I think across healthcare, you're starting to see margins, operating margins of businesses start to contract. Some of the strategies to mitigate that contraction include more disciplined consumption of consumables. To Jordan's point, the 3 gloves versus the 1 glove. If you're lucky and you have the right value proposition, you can have intelligent conversations with the commercial carriers to say, hey, do you recognize the 10% increases in our costs? But in general, there's going to be pressure against that to pass along costs to the patients. But to Jordan's point, healthcare is a very, very challenging environment right now. Until the Medicare and commercial community really recognize the 8, 9, 10% increases in costs, healthcare doesn't have the luxury really of passing along those costs to its patients. It's fairly fixed cost structure, and it really doesn't move as quickly as call it inflation does. And so that'll be an ongoing challenge for all of healthcare, not just the individuals on this call. To Jordan's point as well, I think the third lever is group purchasing. To the extent that groups aren't leveraging a GPO, whether it's on the pharmaceutical or med supply side of the business, that's just really critical that you're exercising all avenues to reduce your costs, whether it's by way of rebates, unit pricing. I don't know if we have coupons, but if we did, Jordan, I think we would use them. But all mechanisms that you can to leverage group purchasing is really, really important. And I think their value proposition to the healthcare community is more pronounced than it was pre-COVID.
And I'll make a few brief comments on this one as well. Have costs gone up? Absolutely. Has our operating margin been affected from it here? Absolutely. What had just been mentioned from Hayden about group purchasing, yes, we're fortunate enough to be a part of that, but the cost, of course, has still gone up over time, almost in line with inflation. Working and speaking with materials director here at AGH and getting firsthand information. Yeah, it's almost on par with inflation. 8%. Some things can be 5%, 10%. The benefit, of course, with group purchasing is you're able to experience some savings in some areas, but in other areas the prices have gone up. That's the bottom line. And a lot of our costs are fixed. We've got to have building, we've got to have staff. The variable, of course, is that is if our staff works overtime, then that's going to be variable cost. And the utility costs this year have gone up as well. We just seen that coming out of this summer across the health system, and all those costs went up. So almost every area that we point to, cost is a factor, and it's challenging. And one of the things, working to renegotiate contracts with payers and all, which we've had success in signing, but the bottom line, it's still not enough. It is not kept up with what's happened with inflation and the cost of labor and all these things. So yeah, healthcare cannot rebound, and it can't pivot as quickly as a lot of the private business out there, where they can truly, as Hayden said, just pass on the cost readily and quickly, to the customer, because we sign contracts with payers and fee schedules and all these things. So it's very difficult for us to be as nimble as a private entity that delivers, a straightforward service, because everyone on this call knows that healthcare is very complicated, and all the paperwork and regulation that are associated with it, it makes it difficult for us to operate. So yeah, cost and rising cost have been a huge factor for us here at AGH.
So for us, we're doing the same thing. We're cutting costs on our supplies. We're paying $25 for a bottle of Lysol, which I can get 3 of them from Sam's now for $12. I mean, we were just getting them from eBay. It was insane. So now we are, still trimming those costs and trying to, find another way to make money. So where they're cutting us in one aspect, we're trying to find another ancillary to pick up where we lost the money. So it's just a constant, how can I cut the dollar and how can I make another dollar? We're constantly on that hamster wheel.
I think the other thing on top of that to add is that patients don't care. They still look at, I see this because I'm a private practitioner and I'm actively involved just by the nature of my business of unfortunately because we collect everything up front. If a patient has a $5,000 deductible and I provide $1,000 of service, they're paying $1,000 that day. And we tell them before they come in. And the comments of, oh, this is ridiculous, and blah, 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 it's just it's insulting, it's never ending. And I would say people still don't feel that they should have to pay for healthcare. And I get it because I'm a doctor. When I go to a doctor's office and they don't collect money up front, it's just kind of ridiculous to me, because I think that that's poor business management. But people still will pay $1,000 for an iPhone without batting an eye. But when they have to pay $50 at the doctor, you're a jerk. I had a lady yesterday for her 4 o'clock appointment call my office at 4 o'clock, state that she wasn't coming because she didn't get a reminder email, because that's our responsibility to manage every little issue. And she slammed the phone up on my front desk saying, well, I'll pay $50, but I'm not coming back there because that's ridiculous. I mean, people, unfortunately, not everyone, so I want to be very careful I say that, but a lot of people still don't have an understanding that this is a business, and it's very hard to run a business when you're dealing with people's health and not have some contention there. And that's the biggest struggle of medicine for me, is that balancing act of being able to make people understand you're running a business, but at the same time provide them a service, a health service, that is.
Well, thank you for that feedback. A lot of good information as to what your practices are doing. We hear a lot about payment collection, payer strategy, also cutting the cost to provide services where you can. One thing to touch on as a final question for this topic, I'd like each of you to briefly discuss where you're at with this, but has your practice considered any alternative payment models, such as a value-based agreement with a payer, direct employer agreements, or some other form of arrangement, and what you were doing to undertake that shift?
Yeah, absolutely.
Go ahead, Hayden. Go ahead.
Yeah. We don't want to be the organization that's behind the curve in terms of setting standards for value-based programs. I mentioned a few earlier, whether it's, on the radiation oncology side, which we know Medicare pretty aggressively, CMS wants to move towards a more value-based model, and the radiation oncology side being at the forefront of that is important to us. And so we are currently working with payers on programs like that, that address, ultimately that movement towards a value-based model. And we're also working with the payers on programs where we can reduce the cost of care by transitioning cases from hospitals to outpatient settings, namely our ASCs. And so if you consider that to be value-based, we are working on value-based programs all the time, at least articulating the value proposition that is having outpatient surgical centers available for patients as opposed to incurring 2 times the cost in a hospital setting. Now, granted, the hospital does amazing things and serves in a critically important piece to the healthcare ecosystem. But as far as urology goes, some of the investments that we've made on the ASC side have been really critical to our value proposition to the payers, and thus we are working on programs that are targeted around reducing the cost of care surgically.
I'll just real quickly state that, I'm only currently in a fee-for-service system. I would certainly welcome the opportunity to look and read anything, and there's been some brief discussion about, value-based. I think the biggest thing, just kind of participating for years in the Medicare quality measures, I think it's very challenging how to really accurately measure, value care or quality care with it has to be exceedingly specific to the practice you run, not just your specialty, but the type of practice that you actually run. Because, one urologist or one podiatrist could specialize in the left foot and the other one the right foot. I only do the left foot. But, at the end of the day, it really has to be very specific to your particular practice. I used to do a ton of diabetic wound care. I lectured all over the region for wound care. I don't do wound care anymore. I kind of just abandoned that and focus on other things. So, the value-based care and quality care measures, the ones that we've done thus far, I don't think have been very beneficial for my particular practice. So I think they have to be very geared towards that, and that's really the key for it to have any value.
Thanks, Tim. I'll jump in. I think we're entrenched in value-based, with what I've mentioned already. And of course, with regarding payer contracts and all that, we've gone through an extensive exercise over the past few years of renegotiating some contracts. So I don't foresee us doing anything anytime soon regarding that. Again, I think a lot of times, because the way healthcare, the way it's run, it's operated, it's regulated, and so on, it's difficult to be as nimble in other businesses. But there is, pardon the expression, there is value in value-based, and we participate and definitely are going to continue going down that track, knowing that fee-for-service will change and ebb and flow. And I'm sure as time goes on, and I've seen it during my career, it'll be lessened, it'll be lessened over time versus expanded over time. So.
We're also fee-for-service. We're negotiating our contracts and doing the same thing with the CMS, the MIPS, and keeping us current with the value that they are asking us for, as well as providing service so that we provide as much as we can under one roof so that the patients don't have to go to more than one facility. They have to go to another waiting room, they have to pay another copay. So do what we can here instead of farming them out. We just try to take care of the whole person.
Awesome. So I really appreciate the feedback there. From my organization standpoint, it's what we're seeing as well. It's starting with, a shift of site of service. It's a consideration of, some value-based models, but until there really becomes some model that can apply to multiple specialties, it seems like fee-for-service is still playing a large role in the healthcare system. But I really appreciate the feedback there on where each of your practices lie today. So With that, I'm going to shift it to Sarah for our final topic, which is mergers, acquisitions, and physician partnerships.
Thanks, Dan. So
Can I jump in here again? Sorry, we have one question in the
sure.
queue. And I know we only have 10 minutes remaining, so I'm going to ask it quickly and then we can try to get through as much of the last section as possible. Are there opportunities to incorporate automation and outsourcing of overhead functions, such as registration and billing, to reduce total costs?
Yeah, I saw that question. I'll answer that. Yes, I mean, in order to keep your practice busy and keep your schedule on time, it behooves you to basically get all the paperwork filled out prior to the visit. So for our practice, and everybody has different EMRs. Sometimes the portals accomplish that. We have on our website, we built out a process where patients go on, and it's pretty much mandatory before they come to the office, unless there are the patients who are 90 years old and don't use a computer, who we ask to get there 30 to 40 minutes before the visit. You can really efficiently get information. All of that data is sent through our website to our office. All of the data is entered into the patient's chart before they're even seen. So you can really efficiently get the information prepared for the visit. And ideally, when the patient walks in, you take their picture for their chart, they go back in the room, and it keeps your schedule going. As far as billing, a lot of the EMRs that incorporate billing software, a lot of the claims download into the chart. They auto-populate the fields with the allowed amounts, disallowed amounts, co-insurances. Certainly having payment portals on your website is helpful. Being able to email bills securely, as opposed to putting them in the mail for 50 cents a pop. Every time you stick a bill in the mail, that's 50 cents. I think they said it cost about $5 to generate a bill. So, reducing billing by collecting up front, of course, because if you're collecting up front, that reduces your overhead. Billing is a big part, and postage is expensive. It's gotten very expensive, and if you can minimize mailing things out, having an interactive website where patients can request, having appointment reminders sent out. Most EMRs do it. I know Athena actually does billing for you. To some extent, they'll do a lot of the posting. There's no follow-up on it. But you can definitely find an EMR that has automation built into it, or there are outside services that will provide that. And you retain patients. It also keeps you have the ability to keep in touch with your patients through an email platform where you can email out newsletters, new services you provide, old services you provide, like a recall system. For example, we make orthotics in our practice. We can send recall notices out to patients, and it's all free because it's through the web as opposed to sending them in the mail.
And this is Tim. Real quick on outsourcing your billing, you give up control. So just you can save costs as far as your operating margin, but you're also giving control to a third party. So that's the only other element I wanted to say on that. Everything else colleague said is spot on.
Well, thank you for that comment. And just for the interest of time, I will make sure Sarah has a few minutes to have a question or two on our final topic today.
Thank you, Aaron. So in 2021, there was an extraordinary volume of mergers and acquisitions. In 2022, we have seen a decline of 34% due to the interest rate hikes, supply chain challenges, and as we've talked about today, the increase in labor and supply costs. That being said, healthcare organizations and private equity are still making deals in 2022. So I'm going to consolidate the last questions into one question. So the question is your practice considering a merger or acquisition? And if so, what has been your strategy to make that successful? So Barbara, we'll start with you because you mentioned earlier that you recently expanded to the Annapolis area.
We're not merging with a hospital system. We are taking over a retiring rheumatologist practice and setting it up so that we can have a fourth office in Annapolis. And that is, you know, they're allowing us to have access to their EMR and their records, and it's a very smooth transition. The gentleman we are working with is phenomenal, just a pillar of the community for all of his 45 years of rheumatology service. So we've expanded, you know, into the Laurel office about 7 years ago, and we just start with one day a week, 2 days a week, and then just do it until our you know, we have full schedules. So we're doing the same thing in Annapolis. We are actually getting a full amount of patients right away, and then we'll open it up to our patients as well that live closer to Annapolis, that they can utilize that office.
Thank you, Barbara. Hayden, are you considering any mergers or acquisitions? And if so, what's your strategy?
Yeah, so in full transparency, as Chief Growth Officer of the business, part of my job is to partner with other organizations across the country, or frankly, even within the state of Maryland. And so the CEO, myself, and the president of the organization, we've completed 10 acquisitions over the last 5 years, four and change actually, partnering with groups in Maryland, in Tennessee, and Colorado, and Arizona. So yes, the answer is absolutely. We are one of, call it, 3-ish consolidators within the urology space. It is a rapidly consolidating marketplace, not too dissimilar from other subspecialties within healthcare. And I think it actually helps mitigate some of the risks and some of the dynamics that we've talked about. Having departments dedicated to HR, procurement, some of the scalable functions that you know, smaller independent organizations wouldn't be able to invest behind on their own. That's generally the strategy. That is, ultimately, you can create economies of scale amongst independent urologists, maintain that independent private practice feel, yet not necessarily you know, be employed by the hospital, so to speak. And so that's been kind of our thesis. We are private equity backed currently, and so you know, we certainly have conversations very frequently about what the private equity backed, you know, marketplace looks like, how things are shaping up in terms of the M&A you know, environment, et cetera. So yeah, intimately involved in that space.
Thank you, Hayden. So from Barbara and Hayden, we're hearing about acquisitions for increasing your geographic reach and also economies of scale. Tim, what about your organization?
Yeah, Atlantic General, our focus as an independent organization is to stay independent. One of the things that we've had discussions on here is affiliations, either with academic centers or other healthcare organizations in the region. So at this time, that's where we stand.
Thank you, Tim. Dr. Stewart?
At this time, I don't have any plans on merging. I mean, certainly I've had some discussions in the past about merging, but nothing's really appealed to me. A lot of my colleagues, however, in the DC area, there's been a lot of mergers of practices into kind of a super group with about 50 different podiatry practices. There's been a big consolidation actually in the Baltimore area within a vascular group of practices. But you know, I still remain alone at this point, and you know, unless the right opportunity comes along, I don't have any plans in the near future for joining anyone, despite the challenges of being an individual practitioner.
Thank you, Dr. Stewart. Do we have any questions from the participants?
I think all the questions have been answered. Thank you, Sarah.
Okay. Well, we're right on schedule at 1 o'clock. So want to thank the panelists for sharing their wisdom, knowledge, and expertise today. You know, the purpose of these type of conferences really is so that we can communicate and learn from each other. Not one person or one organization has all the answers. And today was certainly an example of when you bring a lot of knowledge together, and share it, how much we can all learn from each other. So I want to thank the panelists, Barbara, Hayden, Tim, Dr. Stewart. Thank you so much for your time today. And thank you participants for joining us. Really appreciate it. Dan, did you have anything you wanted to add?
I think
Or
we're good.
Aaron?
I think I'll pass it back to Aaron, but thank you again for everyone for participating, especially our panelists.
Yeah, I want to also echo my thanks for the panelists, for you guys, Dan and Sarah, for putting this together, for Kathy Zito for helping lead the effort, and for our Zoom committee and all that goes into it from the HFMA perspective. And lastly, the panelists, I'm sorry, the attendees for joining today. Want to let you guys know quickly, I know we're bumping up against time here, about some upcoming HFMA sessions. So September 15th, the region is putting on a culture and diversity session. September 28th through 30th, we have our annual fall conference at the Cambridge Hyatt. And then we also have registration open now for our bi-weekly coffee break and networking sessions, which begin Friday, October 7th and go through December 2nd, just 25 minutes on every other Friday, just to get some of that networking back in that we all kind of missed from being in a little bit of a hybrid environment. But again, thanks to everybody, and I hope you enjoy the rest of your day.